Hmm. Okay. Well, so I'm seeing, I'm not getting the link to be able to share with you all, but okay, there it is. All right, so here we go. Guys, today we're going to be doing um, the finance lecture for institutional pharmacy management. I know I have a good number of students in this class, so I'll wait for more of you all to come in. Um, but today we're going to look at the finance. How is healthcare financed? All right, so we have 15 students. So let's go. Good morning, everyone. So today we are looking at the health financing lecture. Let me see what that's called in your notes. It should be called How is Healthcare Funded? So let's get right into it. An overview, how we define healthcare and healthcare systems, financing mechanisms. And we're on to slide 5 now, defining healthcare. And based on the WHO definition, healthcare is all goods and services designed to promote health, including preventative, curative, palliative interventions, whether directed to individuals or populations. And healthcare is provided through healthcare systems. And we have different types of healthcare systems that we're going to look at today briefly. In the health system, it can be defined as all activities whose primary purpose is to promote, restore, or maintain health. And this is from a WHO definition, right? Um, it may need revision. So health financing and demographic changes. So immediately you're going to see here on this slide number 7, the vertical axis is the total population of the world in billions, and the horizontal axis is the time. And you can see that there is a continuous rise in the number of persons in the world, notwithstanding all of the different things that affect the world: war, famine, disease. We have coronavirus disease. What's the death? The death toll at coronavirus for today stands at, let me see if I can get a real life figure here for you. All right, so in the US, I was hoping to get the world figures. I should use this. Anyone know what's the latest coronavirus statistics? Okay, so worldwide, we have 31 million confirmed cases. We have we are just 40,000 people shy of 1 million deaths. So just about 1 million persons of the world perished as a result of a pandemic that has started late December and is still very much present throughout the world. So I want you to appreciate that that although I want you to see the figures that we're looking at here. The world population is currently around 7.5 billion. I think that figure is just about right. India alone is just over 1 billion persons. Then China is quickly following behind, followed by other countries. The death toll from coronavirus is just 1 million, which is essentially 1 million divided into 7.5. I can't even get a figure, but it's a very small amount. It's a very small amount of persons that, although yes, it was rapid. When you still look at it compared to the rest of the world's population, it's a small amount. So in countries that are having better life expectancy, the life expectancy of persons back in 1940, let's just say in the previous century. In the previous century, the life expectancy would have been anywhere around 60 to 65. And now we are seeing life expectancy to be 70 to 75. And that's because of so many health improvements throughout the world that now increase the age of persons that are alive and on earth. And what's the relevance to this? You have more persons available to access health care. That's the point of this discussion. As you have an aging population, other than the fact that you have more persons available that need healthcare, this aging population is one that would require more healthcare interventions than a young population. So the issue with aging population, and it's not an issue, but it's a consideration, it's a fact that you have more people available, one, physically more people, and two, the group of that people, they are the aging population, which means that they are now going to need more healthcare services. And those healthcare services come at a cost. All right? Healthcare services come at a cost. And healthcare is not cheap. I suspected I mentioned this last week, or I would have mentioned it for sure during the summer class. The cost that we pay with health surcharge is $8.25 per week per person. Do you think that 8.25 per week per person can generate enough revenue for healthcare? Let's do some quick maths. Let me get some opinions. $8.25 multiplied by, let's say we have a working population of just about 800,000 people. That's 6.6 million per week, multiplied by 4 weeks in a month. That's $26 million per month from your health surcharge. The question is 26 million per month enough to operate our healthcare system? Let me get some answers. Jahil, I know you're supposed to be here. Let me get some answers on what if you think $26 million is enough to operate our healthcare budget. Sarah is saying maybe. Marie is saying maybe once managed properly. Girls, I'm sorry to say, no, it isn't. And I have to agree with Jahil. $26 million is a drop. Actually, it's not even a drop. $26 million is a vapor droplet in the amount of money that is needed for healthcare. All right. I want to impress upon you this very early on to let you know that healthcare is not cheap. The cost of operating any healthcare organization is not cheap. Healthcare professionals, their salaries are usually on the high range. Healthcare equipment is also quite expensive. And healthcare consumables, although at times we can get them very cheap, healthcare consumables, which includes medication and drugs, have high volume use. So to make a baby privately is about 15. Jahil, you well know, like you're gonna have a baby. Are you gonna have a baby, Jahil? Yes, to have a natural delivery in private healthcare, starts off at $15,000. If there's emergency C-section, there's more. It might reach up to 25, maybe even 30,000. Right? Healthcare is not cheap. And the amount of money that is deducted from our salaries every week is almost a negligible amount of money that is utilized in healthcare. So we have changes in fertility rates and life expectancies shifting the burden of illness toward chronic diseases and injuries. So chronic disease, you look at any healthcare budget, you would see there is a huge chunk that is allocated to dealing with the consequences of chronic disease. And as pharmacists, although you might be institutional, there is a program that was designed to help improve compliance with chronic disease. What is the name of that program? Does anyone know? Can anyone tell me the name of that program? Who's with us again this morning? Kavita R, Sidap, Samantha C, Sidap, Sarah, Sidap, Chelsea, Sidap, Dylan. What's up, Dylan? Sidap. Yes, so CDAP is for Chronic Disease Assistance Program. And it was designed and meant for improving compliance to the population for particular effect on the burden of chronic disease. How, and this is a real public health question, this is a real institutional health question. How does the CDAP program improve compliance amongst the chronic disease population? Tell me, how does it improve compliance? Via what mechanism? We spoke about this mechanism at length, yes, I believe we spoke about this last week, and I'm sure I did it in summer as well. How does the CDAP program, or what is the strategy of the CDAP program to help improve on the burden of chronic disease? What does the CDAP program do? It provides medications to the entire population for a list of medications that for us for specific chronic diseases, the main ones: asthma, high blood pressure, diabetes, glaucoma, and certain mental illnesses and epilepsy, seizures. By doing that, what does it do in principle, from a public health principle? What does it do to the population in improving compliance and reducing the chronic disease burden? Come on, guys. Let me get it's a buzzword in public health. Any guesses? All right, to help you all, before CDAP, what did most patients of government-based institutions had to do to to get their medications from their government clinics? Thank you, Karishma. That was amazing. It was amazing to see the very first answer correct. Karishma Sankar, you won the lecture today. Kai, you're correct. Access, access, access. Please remember this as a take-home point at the end of this course. Access to healthcare improves healthcare delivery. Access to healthcare improves healthcare status. We spoke at because it provides free medication and usually cost of medication deters patients from, hence it improves compliance. Yes, Shakila, it provides free medication. So the access component is two. The two components here of access. One, it is free, so it is easily accessible. And two, it is at all, well, not all, but majority of private pharmacies as well. So it physically gives better access. So in one hand, you have it easily accessible because it's free. All you need is a birth certificate and an ID card to be a citizen or some sort of citizenship status. I know we have immigrants as well. And two, it is also geographically accessible. So it's economically accessible and it's geographically accessible. So it now gives much more patients the ability to get medication to treat their illness properly, improving compliance by them taking their medication on time and properly, thereby reducing the likelihood of complications as a result of chronic disease. And just from a science base, I'm a fellow pharmacist as well. What are some complications that arise out of chronic disease? List out a few there for me with some speed. Come on, Samantha. Come on, Sarah, Chelsea, Dylan. List out some complications quickly here for me that come as a result of chronic disease. Make Dr. Seeley and Dr. Ignacio proud. Some complications that arise out of chronic disease mismanagement or lack of management. Tell me, guys. I'm waiting. Kidney dysfunction, kidney failure, stroke, right? Good, good, good. What else? Death, yeah, well, death. Immobility, good, good, good. And immobility, I like Marie's response of immobility, MI, myocardial infarction, yeah. Immobility now reduces your ability to be productive, to be efficient. You're now immobile, let's say you're wheelchair bound or you lost a hand, etc. Good, very good. So you will appreciate the discussion about the CDAP program being one that helps with reducing the burden of chronic disease via via increasing access economically to medication and access geographically to medication to reduce the burden of chronic disease. Nice question for an exam. Nice question for an exam. And here now you see, okay, in this same slide number 7, the top orange part is the developing countries and the bottom blue part is the developed countries. And you can see there is literally almost no growth in the developed countries, because these developed countries, they have issues with fertility rates and and life expectancies as well. So compared to the developing countries where you have higher fertility rates and higher fertility rates leading to the increase in population. The next slide you are going to be looking at, we're going to compare in slides 8 and 10, we're going to compare two areas, Europe and Africa, where you can see the different territories having different burdens of illness, where Europe has cardiovascular and neuropsychiatric, malignant neoplasms, and other communicable diseases as an issue. These are major issues, 24, 25, 21, and 12% respectively. And when you compare that to the African subcontinent countries, you see the more prominence of HIV/AIDS, malaria, and other infectious diseases. So, so the guys on the African continent are healthier in terms of the sensory disorders, cardiovascular, neuropsychiatric, but they're affected by infection, they're affected by injuries, they're affected by HIV/AIDS. Now, all of this has to do with the the cultural um, the cultural state or the cultural considerations of the community, the continent, the lifestyle, injuries. Remember, some of these territories in Africa, they are in jungle based, so you know it's some of them aren't as developed. And well, this is an old slide, so you know things are way advanced now. Infectious diseases do affect some of these areas that don't have easy access to healthcare, and HIV/AIDS, yes, has been a problem, is now in a better position now. And malaria, we don't even have to go to Africa to talk about malaria. We could actually look right closer to our area, right here in Guyana, right here in Venezuela. We still have malaria being an issue, mosquito-borne illness. Malaria is not an issue in Trinidad, but however, dengue and Zika can be an issue in Trinidad. All right, so you look at the graphs and you can see the point that is being made about the epidemiological transition, because of the different um, fertility rates, different age groups, different social norms, and physical living conditions. All of those things affect the epidemiological transition, right? On slide number 10, you look at demographic changes for health financing. Um, and you would see the point I was making earlier here that as the the age that life expectancy moves from 65 to 74. Remember, as soon as you move into that age where your body is physically going to now deteriorate a bit uh, due to natural causes, you're now going to have an increase in access or demand for healthcare, which would be an increase for financial contributions to healthcare. All right. So we on to now the hard facts of health financing, and we spoke about all of this prior to give you an appreciation that there is a group of persons who cannot who cannot work and who would need to get assistance for healthcare. Then there would be a large group of persons who can work and provide for themselves and who can provide their own healthcare. And then there's another group that also can't work and would need assistance for healthcare. All right, and you'll see this in the other slide, risk pooling number 13. So with health financing, we have essentially four components here. Revenue collection, where does the financing come from to provide healthcare? Pooling, risk pooling, pooling of the different risk groups, resource allocation and purchasing, and finally on the right hand side, the service provision. And I know all those arrows making it look very busy and very complex, but you can take your time and go through it, and you'll see that. Well, this may not completely apply to us here because we have mainly a national healthcare system, but we also have private as well. So you get revenue from taxes, public charges, well, sale of natural resources. So the government revenue, the government gets revenue from all over that must be used, that can be used to purchase healthcare. From the private sector, you see below, there is out of pocket, there is private insurance, there's community-based insurance, there's loans and grants for purchasing healthcare. And then when you purchase healthcare, it can be a private organization, social, government agency, individuals and households. And then you have your service providers, be public providers or private providers, as we have in our country. We just have those two. We have the public and we have the private. All right, so revenues, revenue collection is the different ways in which we raise money. Pooling is the accumulation and management of revenues so that members of the pool share collective health risks. And purchasing refers to the different mechanisms, right? So I just said all those things. So the risk pooling, now in this graph, you'd see where the subsidies required on slide number 13 by persons who are very young and have no income. These people need health care. So some sort of subsidy is required. And the other part where we have the older folks, they also need assistance with healthcare because some of them may have health insurance and some of them don't. Some of them may have health insurance that may not be enough to actually cover all of their healthcare needs. Right? And the dotted line, understand that the dotted line shows that as we become older, the actual amount of money that is needed to manage your healthcare starts to increase exponentially. And I can give some clear examples from my own self. Within recent time, I found myself from taking probably one medication regularly to having to take 1, 2, 3, 4, 5 medications to manage and treat conditions that arise out of life, out of you naturally aging. All right. So this is where the risk pooling comes in. You would see that um, their individual, the companies, insurance companies in particular, they always look at pooling everyone's risk together so that you can now provide insurance for all. So the risk pooling mechanisms, we have National Health Service, Social Security, voluntary, voluntary, voluntary private insurance, and community-based insurance. Now, we don't have any type of community-based health insurance in Trinidad, unless there are, and I'm not aware, because I know there may be some very private and exclusive communities that may do that on their own. But as far as I'm aware, I'm not aware of any. But we do have certainly a national health service that provides health care for everyone who would walk through the door seeking healthcare assistance. Social Security is where we call it, the slide calls it Social Security, but it's essentially you paying for group health insurance with your employer, where you pay a part and your employer pays a larger part. That is the private health insurance. One part of the private health insurance. Then we have voluntary private insurance, which is you on an individual basis. You go out there and you pay for your health insurance, and you do your own assessments. There is no grouping. And as I said, there's community based that I'm not aware that exists in Trinidad. But no pure mechanism works. In Trinidad and Tobago, we have a mix of the first three. We have persons who go to the public service. We have persons who utilize their employers' group health plans. And we also have individuals who pay separately for private health plans. So the purchasing can be done via National Health Services. Um, and what's the national? Does anyone know? Tell me what's the national purchasing um, organization for healthcare products? The HEAL. Who's CFDD? Who's that? I don't know who is CFDD. Guys, tell me who is or what organization is our national purchasing organization for healthcare products and services, or goods and products, I should say. Who is it? No, no, Jahil, no, chemistry, food and drug, they don't purchase anything. Chemistry, food and drug is a regulatory body. So that's different to um, NIPDEC, yes, Shakila, but before NIPDEC, who is the purchaser for national health services? Who is the one who's paying the money? Sarah, Katrina, Marie? Who is the purchasing minister? That's right, the MOH. The Ministry of Health is the organization that has the budget, the finances to purchase healthcare goods and products and services. Shakila's answer is NIPDEC because yes, NIPDEC are hired by Ministry of Health. So understand the arrangement. Ministry of Health is the purchaser. They subcontract to NIPDEC. which is C40 down at Chaguaramas, commonly known as C40. And this NIP deck purchased goods and products, pharmaceuticals and non-pharmaceuticals, for use throughout the healthcare system. The Ministry of Health also purchases labor in the form of doctors, pharmacists, nurses, wards attendants, radiographers, lab technicians, etc. The Ministry of Health also purchase insurance from different health companies for their employees as well. So the Ministry of Health is a purchase is the purchasing agent for our National Health Service. And for our private health service, who would be the purchasers of healthcare? Who are the ones purchasing in the private market for healthcare? Private healthcare. Who's doing it? Traders? Which traders, Jahil? Tell me which traders you're speaking about. Who is the purchasing agents for healthcare in the private sector? Come on, guys. Who are the purchasers of healthcare in the US of A? It's the same people who purchase privately down here and all over the world. Nobody? It starts with I. Individual. Individuals, yes. Individuals, yes. Out of pocket, Sarah. So that's yes. I will accept that answer for out of pocket. So that's voluntary involuntary purchase of insurance. Yes. But I was not talking about voluntary. I was talking about private. Well, voluntary is private, yes, but I was talking about something else as well. And it does start with I. So you can go to as Jahil said, 15,000 to go and have a baby in private healthcare. You can take that 15,000 out of your pocket, or you can take that 15,000 out of your pocket, or swipe card, insurance. Yes, Shakila, insurance. So the insurance companies, whether it be Maritime, Tatil, Sagicor, West Indian Insurance, whoever insurance it is, insurance companies now also purchase healthcare in the private market. All right. So in the national market, you have the Ministry of Health being the purchaser. In the private market, you have insurance and individuals being the purchasers of health care. Good. So resource allocation and purchasing decisions have important implications of cost, access, quality, and customer satisfaction. Now keep that in mind, guys, because some of you may become public healthcare managers, whether be it in pharmacy or whether be it in a larger role as a GM of primary care or something like that. And take note of what I'm saying. Resource allocation and purchasing decisions have important implications for cost of the service, access to the service, the quality of service or goods, and customer satisfaction. And I know I would have mentioned that customer satisfaction is something that might be lacking and there has been an aggressive attempt by some of our public healthcare institutions to improve on it where they now have their general managers of quality, and they have quality departments in each facility. So it's a work in progress. All right. So the market structure, so purchasing and remuneration of providers. Well, Sarah's option was the single payer. Sorry. Um, right. So the person who's out of pocket is a single payer, and they can go directly to their health agency to get their health care. In terms of the public person who's accessing the public network, the national purchaser is the one that is going to be getting them all of their healthcare. And you see the different countries. If you look on the graph, we're on slide 16, guys. If you look on the graph on the slide, you would see countries such as Greece, Iceland, Korea, and Singapore. They have one national purchaser. In countries such as Australia, Canada, Denmark, Italy, Norway, and the US, they have a regional purchaser of goods and healthcare services. And lastly, we have multiple non-competing insurers and multiple competing insurers. Just as in the US as well is there again, Netherlands, Switzerland, and the non-competing is in Austria, France, Luxembourg, and Japan. So there you have different strategies and different approaches used all over the world for purchasing of healthcare. So I'm seeing it's now 10:59, so we'll take a break. When we come back, we're going to finish up this health systems and hopefully we can get IT done as well. All right. So we're going to take a break now and return at 11:05. Sorry, at return at 11:15. All right. So see you on the other side of 11.